Good afternoon, everyone. Center of Excellence in HIV Care, School of Tropical Medicine, Kolkata, welcomes our speaker and all participants to the Regional Distance Learning Seminar Series. Dr. Dolanchampa Modak is our speaker today. She will elaborate her discussion on post-exposure prophylaxis, PEP, for HIV. Dr. Dolanchampa Modak is the Associate Professor of Tropical Medicines and Deputy Program Director, Center of Excellence in HIV Care at School of Tropical Medicine, Kolkata. She is also a master trainer for NACO and a faculty for postgraduate diploma in HIV medicine course for IGNU. She has several publications in national and international journals. I request Dr. Modak to kindly start the session.
Good afternoon, everybody. Today's session is about post-exposure prophylaxis in HIV, which is known to everybody, but you should update yourself with this class each and every time. NACO has updated this post-exposure prophylaxis very soon, very recently. So we will discuss the post-exposure prophylaxis in such a way that at the end of session, we will understand the risk of transmission of HIV through occupational exposure and the first aid after occupational exposure, counseling for persons reporting occupational exposure, prescription of PrEP and the follow-up procedures and documentation. All these are very important. Now, what is post-exposure prophylaxis? Post-exposure prophylaxis is a comprehensive management institute to minimize the risk of infection following potential exposure to bloodborne pathogens, not only HIV, but also hepatitis B and C. And it is a standard protocol for preventing chance of getting HIV infection when the healthcare provider is exposed to a source person known to be or possibly HIV infected. NACO guideline describe the risk of infection and preventive measures and the steps to be followed. Now, post-exposure prophylaxis management protocol is an important element of workplace safety. So we must know the different type of exposure. The two types of exposure. One is occupational exposure, that is exposure happen in the workplace environment, and another is non-occupational exposure, refers to exposure to the potential bloodborne pathogen outside the workplace environment. And type of exposure, number one and the most common is percutaneous injury, maybe needle stick injury or cut with a sharp object, or contact with the mucous membrane of eye, mucous membrane of mouth and nose, or with contact with the non-intact skin like chopped skin or dermatitis. And even in place of intact skin, if there is prolonged contact with blood or other potentially infectious body fluid. Who are at risk of this occupational risk of bloodborne infections? Number one, nursing staffs and students. They are most vulnerable section, and emergency care provider, labor and delivery room personnel, surgeon and operation theater staff, laboratory technician, physicians, intern and medical students, dentist and health facility cleaning staff, mortuary staff, and the clinical waste handlers. So these are the staffs, human sector, which are more vulnerable for as occupational exposure to HIV. Now, healthcare worker during disposal of sharp from an operation theater has a prick on his finger after a HIV positive delivery. So, who are at risk of getting an infection? Number one, an healthcare worker, and number two is internist during had a splash of pleural fluid on his face from the HIV positive individual. Now, so we must know that the type of body fluid which are considered to be at risk and which are considered not to be at risk. So the blood, semen, vaginal secretions, CSF, synovial, pleural, peritoneal, pericardial, any serosal fluid, amniotic fluid, and other body fluid, if contaminated with visible blood, are all considered should be as infectious material for spreading of HIV, hepatitis B and C. And which fluids are not? Tear, sweat, urine, feces, saliva, sputum, and vomiters. Sputum and vomiters, if are not contaminated with visible blood, are considered as non-infectious material. Now, we must know the risk of HIV transmission with different type of exposure. Through blood transfusion, it is around more than 98%. Mother to child infection without any intervention, it is 0.1 to 1%, 20 to 40%. And with intervention, like with ART, it is around less than 1%. Sexual exposure, it is 0.1 to 1%. And it is more with the vaginal route, 0.05 to 0.1%. Anal route, it is less common, but more in MSM, 0.065 to 0.5%, oral route 0.005 to 0.01%. Now, in case of injection drug users, it is around 0.67%, needle stick injury 0.3%, and mucous membrane splash to eye or oronasal cavity, it is 0.09%. Here we must notice that in case of needle stick injury, it is around 0.3%, but in case of hepatitis B, it is around 9 to 30%, and HCV, it is around 1 to 1.8%. So, the risk depends upon the type of exposure and type of transmission and also type of body fluid and route of contact of exposure. So, we must discuss one case scenario and different case scenario, like a medical officer presents to emergency care for evaluation of needle stick injury that has occurred 2 days ago while inserting an intravenous line to an HIV positive patient. So duration is also important. Can you start PEP in this situation? So we must know that what is the risk of contracting HIV? Are there factors that might affect the risk? How effective is PEP? Is it too late to start PEP? What are the drawbacks of starting PEP? Which regimen should be considered? What follow-up should be arranged? All these we must know when we prescribe PEP. That I have previously described that through percutaneous needle stick injury, chance of HIV acquisition is 0.3%, hepatitis B is around 9 to 13%, and hepatitis C is around 1 to 1.8%, and mucous membrane exposure is around 0.09%. So chance of HIV acquisition is much less compared to hepatitis B and C. So we must take care of these two other viral infection also. And chance of acquisition of infection also depends upon the viral load of the source, whether gloves is used or not. There is evidence that 50% decrease in volume of blood transmission when there is use of gloves. Hollow bore needle versus solid bore needle. When a surgeon operates with hollow bore needle, the blood material can enter into the hollow diameter of the needle. So there is chance of exposure, much more exposure than compared to solid needle, where the blood material cannot be present within the needle. And drying condition, must know that HIV virus cannot live outside the human body much longer time, usually less than 1 minute. And there is 10-fold drop of infectivity every 9 hours. So during an exposure happened, now what to do? Step 1, management of the exposure site, that is through first aid. Step 2, establish the eligibility of PEP. Step 3, counseling must be done for PEP. about the PEP, about the HIV infection, about window period, acute seroconversion illness, and what not to be done during this period, window period, and during this 6 months period when what is needed to for further repeated testing to declare a patient as HIV negative. Number 4, assessing the need of PEP and prescription of PEP. Number 5, laboratory evaluation. And number 6, follow up. All these things are equally important. So, management of exposure through first aid. If there is if the skin is pierced by a needle stick or the sharp instrument, what you should not do. Do not put the injured finger in the mouth in a reflex action. Immediately wash the wound and the surrounding skin with water and soap and rinse. Do not rub the skin. Do not use the antiseptics or the skin washes, bleach, chlorine, and alcohol because it will further invite the irritation and more wide area for exposure and for penetration of HIV virus. And consult our designated physician of the institution for management of the exposure immediately. In case of eye, you must irrigate the exposed eye with water or normal saline immediately. Tilt the head back and ask the colleague to gently pour water and or normal saline over the eye. If there is contact lens, leave them in place while irrigating as they form a barrier over the eye and will help to protect it. And remove the contact lens and clean them for in a normal manner so that it can be used later. Do not use soap or disinfectant on the eye and consult with the designated physician of the institution for management of the exposure immediately. In case of mouth should be rinsed with thoroughly with water or saline and spit again over 10 minutes and don't use soap and disinfectant. Now, step 2, that is the establishment of eligibility of PEP. First, you have to establish that the injury has already happened with blood or bloody other body fluids and other potential infectious material or instrument contaminated with one of these substances. If it is yes, then what type of exposure? Mucous membrane or skin integrity compromised or intact skin or percutaneous exposure. If there is intact skin, then no PEP is required. If there is mucous membrane exposure or skin integrity is compromised, then you should consider the volume of the infected material. If there is small volume or the few drops of for the short duration, that should be considered as exposure code 1. If there is large volume of fluid or major splash, longer duration, exposure code 2. And if there is percutaneous injury, then less severe solid needle or superficial scratch, exposure code 2, or more severe hollow bore needle deep injury, then it should be considered as exposure code 3. Then you have to know the category of exposure. What is mild exposure? If there is mucous membrane or non-intact skin with a small volume or contact with eyes or mucous membrane or subcutaneous injection following a small bore needle, then it is considered as mild exposure. What is moderate exposure? Then exposure to mucous membrane with large volume or percutaneous superficial exposure with solid needle or superficial cut or needle stick injury or with a penetrating glove. That is most common exposure is moderate exposure, which we face daily in our daily life. And severe exposure, if there is an accident with high caliber needle, more than 18 gauge, with visibly contaminated blood, a deep wound, hemorrhagic wound, or very painful transmission of a significant volume of blood on an accident with material that has previously been used intravenously or intra-arterially, then it should be considered as severe exposure. Wearing of gloves is one of the standard workplace precaution, but glove punctures do happen. You always consider that. In case of AEB, with material such as discarded sharp needles, dried contaminated blood. Transmission risk remains for a week for HIV, and risk remains more significant for hepatitis B and C as they survive longer than HIV outside the human body. Now we have done the source code, exposure code. So in case of exposure code 1, that is minimal risk, and superficial source code 1, then PEP is not recommended. In all other situation, or PEP is recommended. And whenever you recommend PEP, it should be at least for 20, it is considered for 28 days, no less than 28 days and no more than 28 days. It is based on the animal model study that 28 days PEP is optimal. And if there is the source code is unknown, then consider PEP if HIV prevalence in high in given population in the region or risk categorization. Now counseling. It is very important. Receive appropriate information about what PEP is and risk and benefit of PEP for an informed consent. It should be made clear that PEP is not mandatory but needs to be taken. And the patient or the exposed person must understand the detail of the window period, baseline test, drugs that are used, their safety, their adverse effect, and also their efficacy. Person must be counseled on safe sexual practice till both the baseline and 3 months test are found to be negative. And receive counseling women regarding the use of PEP and pregnancy and breastfeeding. The patient must not be pregnant during the follow-up period of 6 months during PEP taking and follow-up period for further testing, and must not breastfeed the baby. And psychological support is almost always important. Many people will feel anxious and some people getting depressed. Some may require further specialized psychological support. Be informed about the risk and measures that can taken to help relieve part of the anxiety. And in case of exposed person, opt out for PEP even after intensive counseling should be advised for testing for HIV, hepatitis C and B at baseline 12 weeks and 24 weeks from the date of exposure. Now, when should PEP be started? It is shown that the PEP should always be started within first 2 hours of exposure. Animal model study shows that the valuability or the efficacy of PEP decreases with when of time, when we with time. PEP is most efficacious when it is start within first 2 hours and is not effective when it is start beyond 72 hours of exposure. But one cannot deny the of giving PEP if the patient or exposed person wants to take PEP even beyond 72 hours. So we must understand why this first 72 hours is important. So when an HIV virus is when the source person is exposed with the HIV virus through needle stick injury or cut injury or mucosal membrane, then the first line of defense who came? Usually the dendritic cells, macrophages. Then they acts as a carrier and take the HIV virus to the CD4 helper T lymphocyte. And then the CD4 T helper lymphocyte with can identify the virus. They find it, fuse it, and attach it to the surface of CD4 helper T lymphocyte. And it will take around 0 to 2 days. And then the virus goes to the regional lymph node. And in the regional lymph node, with the help of enzyme reverse transcriptase followed by the virus integrated with the host cell DNA, then multiply within the host cell DNA, and in the cytoplasm it produces HIV RNA, and with the protease inhibitor it becomes small pieces of HIV RNA. Then with the integrase in a enzyme, it is integrated, and after bursting of the niche helper T lymphocyte, it goes to the human circulation. So this takes around 4 to 11 days. When the HIV virus spread to the regional lymph node and to the circulation, then you cannot halt the replication of the virus. So PEP is should be taken to prevent the replication of the virus within the helper T lymphocyte cell as early as possible within first 2 hours before identification of the virus with the helper T lymphocyte, and before the virus present in the circulation, that is done within 72 hours of exposure of the virus. That's why animal model studies shows that PEP is best if it is taken within first 2 hours, and it is ineffective if it is taken beyond 72 hours. I have already explained. So key consideration for prescribing PEP. PEP should be started as soon as possible, preferably within 72 hours of exposure. If healthcare personnel present after 72 hours of exposure, PEP can still be used after counseling about its effectiveness. Prophylaxis needs to be continued for 4 weeks, and PEP should be made available in emergency department, in labor room, intensive care unit, and operation theater. All hospital members must know whom to report to for PEP and where PEP drugs are available. Now, the key consideration for prescribing PEP. Exposed person should go to the designated medical officer or clinic at the earliest for complete risk assessment, HIV counseling, testing, and PEP. Counseling to be done also by the prescribing doctor. In case of sexual assault, the PEP should be taken given to the exposed person as a part of overall package of the post-sexual assault care. And in case of pediatric sexual assault, the cases need to be notified to the concerned authority of the nodal officer in the state or the city as per POCSO Act 2012. Now the recommendation for PEP for adolescent and the adult. For adolescent and the adult more than 10 years of age and weight more than 30 kg body weight, preferred regimen is tenofovir 300 mg, lamivudine 300 mg, dolutegravir 50 mg fixed dose tablet, 1 tablet daily for 28 days. And there are alternative regimen. If one cannot take the dolutegravir, then lopinavir ritonavir is another option. If one cannot take the dolutegravir or lopinavir ritonavir, efavirenz can be the other option along with tenofovir and lamivudine. It is very important to take the PEP immediately within first 2 hours and preferably within 72 hours of exposure. Healthcare provider should be counseled about the safety of the PEP drugs. Duration of PEP is 28 days regardless of PEP regimen. In case of children, if it is less than 20 kg, the first choice is abacavir 60 mg, lamivudine 30 mg with dolutegravir 10 mg. If it is 20 to 30 kg, then the dolutegravir can be given in the 50 mg tablet. If anyone cannot give the abacavir, then zidovudine should be used in place of abacavir and lamivudine, and as zidovudine, lamivudine, and dolutegravir. In case of children less than 20 kg, dolutegravir should always be used as with 10 milligram. And if it is more than 20 milligram, the dose of dolutegravir should be 50 milligram. Now, situation that may require an expert opinion. Some situation needs expert's opinion, likely that if source person's HIV status is unknown, PEP is advised on case-to-case basis. It depends upon the severity of exposure and epidemiologic likelihood of HIV transmission. Like in our hospital, where more than 50% beds are occupied with the HIV infected persons, if there is an unknown source needle stick injury, we should not avoid giving prescribing PEP to an healthcare professional. But if their prevalence is very low and physician must consider case-to-case basis and the endemicity of the HIV infection before prescription of PEP. Do not delay in PEP initiation if there is known or suspected pregnancy, breastfeeding issues in the exposed person, and the source patient is on ART or possibly has a HIV drug resistance. Refer consult with an expert as soon as possible and refer to an expert in case of drug intolerance, any major toxicity, non-adherence, or complicated cases like major psychological issues are there. So in these are the different situations. One must take the opinion of expert regarding PEP. And now another two important thing, hepatitis B and C infection. There is no prophylaxis for hepatitis C infection currently, but in case of hepatitis B infection, if the hepatitis B vaccination status of the exposed person is not known, then is known that he is not vaccinated, then complete hepatitis B vaccine series should be given to the exposed person. If the exposed person says that he is vaccinated, but hepatitis B anti-HBs titer is not known, then give the hepatitis B booster dose of vaccine. But in other situation, like he is vaccinated, but it has done before more than 5 years ago, then also again a hepatitis B vaccine booster should be given. Please note that if the hepatitis B vaccine is not available, then the antibody level testing is not always necessary. Hepatitis B vaccine should be given as soon as possible after the exposure. Do not wait for hepatitis B surface antibody level results. If the test is done, adequate level is antibody level is 10 more than 10 international unit per liter. If it is there, no hepatitis B vaccination should be required. Now, the laboratory investigations. What are the laboratory investigations? Baseline investigations for to know the status of the exposed person, whether he is already infected. So there is no need of PEP, there is need of ART. So baseline HIV testing, hepatitis B, C, and sometimes anti-HBs, AG, if the patient says that he is vaccinated. Complete blood count, serum transaminases are important. Now, follow-up test 7 days, 14 days, 28 days, and 12 weeks after starting PEP is required. In first 2 to 4 weeks, what are the tests needed? Complete blood count, creatinine, fasting blood sugar, random blood sugar for patients on dolutegravir. Because dolutegravir dose, if the patient take metformin with dolutegravir containing regimen, dose of the metformin should not exceed 1000 milligram or 1 gram. Monitor the acute seroconversion illness during the window period, 3 to 6 weeks of exposure. So what are the seroconversion illness? During acute HIV illness, there is flu-like symptoms with arthralgia, myalgia, rash, rhinorrhea, headache, pharyngitis, hepatosplenomegaly, acute meningitis-like symptom, aseptic meningitis. Even the exposed person may develop Guillain-Barré syndrome. So physician must know but even the exposed person must report that the symptoms regarding seroconversion illness and must give advice regarding the blood donation. Exposed person must not donate blood, must not breastfeed their baby, and must not get pregnant during this follow-up period. of this 6 months period. And person should use universal precautions, refrain from unprotected sexual activities, adherence and adverse drug reactions. Counseling should be done. And in the 6 weeks, HIV test should be done. It should be repeated after 3 months and 6 months. Now, availability of PEP drug. PEP should be available and accessible round the clock. In all cases, the first dose of the PEP should be offered as soon as possible, preferably within 2 hours once the decision to give PEP is made. PEP regimen should be made available from ARV drug stocks in the casualty, in OT, labor room, ICU, emergency ward with proper documentation. An exposed person should go to the designated clinic or officer at the earliest for a complete risk assessment, HIV counseling and testing and PEP. All the hospital members must know whom to report for PEP and where the PEP drugs are available. A regular checkup should be made for expiry of the drugs with replacement of short expiry drugs. And PEP cases should be documented in the accidental exposure form and the PEP register, and reporting of drug consumption should be done in IMS. Post-exposure prophylaxis is the second best approach to occupational exposure to HIV. So what is the best approach? Best approach, you must know that what are the type of injury that you should avoid during your work in hospital environment. It is noted that 52% injury happen during the use of needle stick injury or sharp object injury, and 13% and 13% injury happen during recapping or in preparation of reuse or other procedural steps, and very less injury happen during after use or before disposal, after use or disassembling, during disposal, putting items into the container while retraining patient, and between steps of multi-steps process, and after use device left on the floor, table and the bed. So you must know that during the procedure, during the work done, 52% injury happen. So one must be cautious to avoid this injury. And what are the type of objects from where the percutaneous needle stick injury happen? 31% occurs from the other sources, and 24% from the disposable syringe, 26% from the suture needle. So you must be very cautious during use of disposable syringe and the suture material. And you must also be cautious during use of scalpel blade, scalpel reusable, vacuum tube, wing steel needle butterfly, retractor of skin, bone hooks, electrocautery, bearing, drill, bit or bar, pre-filled syringe, and use of this material also. So prevention of exposure to HIV, we must know that we must follow the universal precautions, that must always wash your hand thoroughly and in the proper way before and after doing the work. Avoid occupational exposure to blood and other potentially infected material. And we must always use the personal protective equipments. So what are the personal protective equipments? That is, always use face mask, cap, and consider all blood samples infectious. Follow the universal procedural precautional practices during any procedure like ascitic fluid tap, pleural tap, CSF fluid tap, and safe disposal, safe handling of the sharp instrument should be done, and always use the needle destroyer after using the needle. So these are the first line measures one must take to prevent the accidental exposure to HIV, hepatitis B and hepatitis C. So in this class, the key points to be noted: that make HIV transmission to a healthcare personnel a minimal possibility, implement universal work precaution plan in the facility, consider all patients or the samples as potentially infectious, PEP initiation within 2 hours, preferably within 72 hours, never be delayed due to unavailability of the source status or HIV test result. Documentation and reporting of each such injury or exposure is essential. Sensitization of healthcare personnel and accessibility of the PEP round the clock is needed. Person exposed to the risk of transmission of HIV is also at more risk of getting infected with hepatitis B and C, so it should be considered simultaneously along with HIV. So these are the few points to be noted. And with this slide, I am finishing this class. Thank you all for participating in this class. Thank you.
Thank you so much, ma'am, for facilitating this session. Any questions from the participants? Please feel free to unmute and ask questions. You can also put your questions in the chat box. Any questions on post-exposure prophylaxis for HIV? Ma'am, I don't think there are any questions.
Okay, thank you.
Thank you, ma'am. We'll quickly run the feedback form, ma'am.
Okay.
Kiran sir, can we have the feedback poll? Thank you. Requesting all the participants to please attempt the feedback poll. Do not close the window or leave the session until and unless you complete this. There are 5 questions in all. Please scroll through the questions and click on the answer of your choice. Requesting all the participants to please attempt the feedback poll. We'll wait for another 2 minutes. Please scroll through the questions and click on the answer of your choice. Kiran sir, we can end the feedback poll now. Thank you, everyone. Thank you, ma'am. The QR code for downloading the mobile app for treatment guidelines, that is the national guidelines for HIV care and treatment, is visible on your screen. You can scan the QR code and download the guidelines. We'll wait for another minute. In case someone wants to download the guidelines, national guidelines for HIV care and treatment, the one that was published in December 2021, please scan the QR code on the screen. Once again, thank you, ma'am, for facilitating this session. Thank you to all the participants for patient listening. We'll conclude the session now.